Hello students, welcome to this session. Let's study infection. Now let's see types of infections. So primary infection is the initial infection. Reinfection is subsequent infection by same organism. Secondary infection, subsequent infection by new organism. Focal infection, it is localized infection. It can be superficial or deep. Superinfection, the second infection in already existing infection. Cross infection, new infection acquired from other host. Nosocomial infection, it is hospital acquired infection. Heterogenic infection, it is physician or medical paramedical staff induced infection. Depending on source, the types of infections are endogenous infection and exogenous infection. So endogenous infection, it is from within body of host. Example, normal flora. So two types of normal flora, transient flora and resident flora. So transient flora is present at some point of time, not always, and resident flora, they are present constantly. It prevents permanent colonization of body by other microorganisms, that are pathogenic microorganisms. The exogenous infection from outside body of host, so that is environment, so air, water, food, hospital equipments like thermometers, stethoscope, blood pressure apparatus, bedpan, urinal, trolley, etc. Then healthcare workers, other patients and carriers. Types of infections according to the clinical manifestations. So they can be asymptomatic and symptomatic infection. Asymptomatic when no symptoms are seen, and symptomatic when symptoms are seen. So it can be acute infection when the symptoms are seen for a short period, and chronic infection when symptoms are seen for long period, that is more than 6 months of duration. Latent infection when infection is in hidden form. Types of infectious diseases depending on the epidemiological pattern. So it can be endemic, hyperendemic, epidemic and pandemic. So endemic infection when it is persistent in particular area at lower rate. Hyperendemic, the infection occurs at much higher rate than the usual in particular geographic area. Epidemic when infection occurs at higher rate in particular area. Pandemic when infection spreads to large areas of the world. Example, COVID-19. Healthcare associated infection, that is hospital acquired infection, is defined as new infection occurred in a healthcare facility by a patient after 48 hours of the admission, which was neither present nor incubating at the time of admission. Community acquired infection or associated infections refers to the infections which developed in the community or within 48 hours of the admission to healthcare facility. Some infections can be localized. They are present in local area. They can be superficial or deep, and they can be generalized, like bacteremia, presence of bacteria in blood; septicemia, presence and multiplication of bacteria in blood; pyemia, pyogenic bacteria are circulating in blood, characterized by development of abscess in the various organs. Source of infection can be endogenous, that is normal flora. It can be transient and resident flora. Exogenous can be environment or hospital equipments or healthcare workers or other patients and carriers. Sources can be animals, so they are called zoonotic diseases if the infection is from animals. So bacterial infection like plague, viral infection like rabies because of dog, then protozoal infection, toxoplasmosis because of cat, helminthic infection, hydatid cyst because of dog. So these are animal acquired infections. Then insects, they are called arthropod borne diseases. So they are vectors, can be mechanical vectors like flies, they cause dysentery, typhoid. Biological vector, they cause Aedes mosquito cause yellow fever. So mechanical vector when there are no multiplication or the fertilization. Then biological vector when some sexual cycle present in that vector is called biological vector. Then other source can be soil and water. So bacterial spores can be tetanus. Then parasites like microorganisms causing vibrio, hepatitis, viruses. Then food, it can be external contamination, food poisoning or staphylococcal poisoning. Then pre-existing infection, meat, animal products. Carrier, a person who harbors infectious agent in absence of clinical symptoms but transmits infection via contact or secretions. So the types are healthy carrier without suffering from disease, convalescent carrier who recovered from disease and continue to harbor and shed pathogen from the body. Temporary carrier, they shed organisms for less than 6 months period. Chronic carrier, they shed organisms for longer periods. Contact carrier, acquire pathogen from patient. Paradoxical carrier, acquire pathogen from another carrier. Methods of transmission: contact, like sexually transmitted diseases like syphilis, gonorrhea. Indirect contact can be fomites, inhalation, droplet nuclei, ingestion, waterborne like cholera, foodborne, food poisoning, handborne, dysentery, inoculation, so tetanus, rabies, syringes, needles causes HIV, hepatitis B, hepatitis C because of the blood transfusion. Then congenital, it can be vertical transmission, syphilis, rubella, or iatrogenic can be because of the lumbar puncture, catheterization, transfusion, dialysis, or organ transplantation. Factors responsible for microbial pathogenicity. So they are adhesion. So because of the fimbria, they are adhesion to the host cells. Invasiveness, so it causes spreading. It can be localized or generalized. Toxigenicity, so it is because of the endotoxin or exotoxin. This we will see in detail later slide. The plasmid can be R factor. Bacteriophage, so beta or tox plus gene bacteriophage in diphtheria. Communicability, spread from one to another individual. Other bacterial factors like thrombin-like enzymes seen in staphylococci, fibrinolysins, hyaluronidase, leukocidins, hemolysins. Bacterial appendages like capsule or bacterial VI antigen in Salmonella, K antigen in Klebsiella. Biofilm is a group of bacterial cells which stick to each other on a surface. Example, prosthetic valve. Infecting dose is minimum inoculum size that is capable of initiating infection. Route of infection, any route or specific route required. So these are the factors causing microbial pathogenicity. Now we will see endotoxin and exotoxin differences. So endotoxin, lipopolysaccharide in nature, exotoxin, proteins. The source, endotoxin, form part of cell wall of the gram-negative bacilli, and exotoxin is secreted by gram-positive and gram-negative bacteria. The endotoxin released after cell lysis, exotoxin actively secreted by bacteria. Endotoxin heat stable, exotoxin heat labile. Endotoxin no enzymatic action, exotoxin action often enzymatic. Endotoxin non-specific, no specific tissue affinity, active very large doses and weakly antigenic, ineffective and not used for vaccine. Exotoxin specific action on particular tissue, specific tissue affinity, active in minute doses, highly antigenic, effective by neutralization antibodies, and toxoid forms are used as vaccine. Example, tetanus toxoid, diphtheria toxoid. Hello students, today we will have lecture on immunity. We will see definition. So it is defined as resistance offered by host against microorganisms or any foreign substances. Then what are the types? So it is divided into two types mainly, innate and acquired. So innate immunity or native immunity, it is the resistance by virtue of genetic and constitutional makeup. So it is present since birth. And then again it is divided into two types, the non-specific and specific. And acquired immunity, it is also called as adaptive immunity. So it is a resistance acquired during the lifetime. It is different from the inborn. And then it is again divided into two types, that is active and passive immunity. Then we will see difference between innate and acquired immunity. So innate immunity, it is present since birth, microbial exposure not required, it acts immediately, no memory present, and mechanism can be barriers like anatomical barrier, physiological barriers, or secretory products in the body and normal resident flora which protect from the pathogenic organisms. And it is divided into two types, specific and non-specific immunity. Then acquired immunity, it is acquired during course of life, microbial exposure is required, it does not act immediately, it takes some time to act to form the antibodies, and then memory is present for the second or subsequent infection, and mechanism is of by T cells or B cells, and it is divided into two types mainly, active and passive, and each is divided into natural and artificial. So now, what are the components of innate immunity? This we'll see in detail. So anatomical barriers, physiological barriers, then resident flora, phagocytes, natural killer cells, and complements present in blood. And the components of the acquired immunity, they are T cells, B cells, and complements. So now, this we already saw. Types of immunity, innate immunity is non-specific, and then it is divided into species, racial, and individual. And again, specific immunity, it is divided into species, racial, and individual. Now we will see factors responsible for the innate immunity. So it is age, extremes of ages. So extremes of ages, they have low immunity. Then hormonal influence. So endocrine disorders like diabetes mellitus, hypothyroidism, they increase susceptibility to infection. So that means low immunity. Then nutritional status. So malnutrition, this cell-mediated immunity, and hormonal, the humoral immunity, that is antibody-mediated immunity, is low in malnutrition. The mechanism of immunity, innate immunity, so this is first line defense. So examples are, first is anatomical barrier. So skin, mucosa. So skin, intact skin and mucosa prevent entry of microorganisms. The sebum present in skin, it is antimicrobial. The mucosa prevent entry of microorganisms. Mucus, cilia, they are present in that mucosa, propel microbes outside. Example, cilia in respiratory tract. Then coughing, sneezing, and urine flush, these all mechanisms, they remove bacteria. Then physiological barrier, so temperature, which inhibit growth of the bacteria. Low pH, that is gastric acidity, inhibit growth of bacteria. In secretory products, they inhibit growth of microorganisms. So few examples are there. So in saliva, it is lysozyme. In tears, it is lysozyme. In gastric juice, it is HCl. Trypsin and protein digesting enzymes are present in intestinal juice. Then bile salts, they rupture the bacterial cell membrane and then thus cause the killing of the microorganisms. Then lactoferrin bind to the iron and inhibit bacteria. Spermine inhibit bacteria in semen. Sebum contains chemical toxin to kill the bacteria. So here you can see examples of non-specific defenses. So mucous membrane are physical barriers to microbes. Lysozymes present in tear and saliva. Then mucus coated hairs in the nose trap inhaled particles. Mucosa of the upper respiratory tract is ciliated, and that cilia in trachea help moving out the bacteria away from the lower respiratory passage. Flushing mechanisms like coughing, sneezing, lacrimation, salivation, peristalsis, urination, so they all help to flush out the microorganisms. Then gastric, so that hydrochloric acid neutralizes Helicobacter pylori neutralizes acidic pH, and that is why Helicobacter H. pylori grow in stomach. So blood complements iron binding proteins like lactoferrin, transferrin. So they all inhibit growth of microorganisms. Lysozyme, enzyme that degrades peptidoglycans. So gram positive bacteria are more susceptible than gram negative bacteria. Then phagocytes like macrophages are chief phagocytic cells. Free macrophages wander throughout a region in search of cellular debris. Then Kupffer cells present in liver and microglia present in brain are fixed macrophages. Neutrophils phagocytic when encountering infectious material. Eosinophils are weakly phagocytic against parasitic worms. Mast cells bind and ingest a wide range of bacteria. So these all types of phagocytes, they inhibit or kill microbes. Then now we will see acquired immunity. So acquired immunity is divided into naturally acquired and artificially acquired. And naturally acquired is again divided into active and passive. So we'll see example of active and passive. So active antigens enter the body naturally. Body produces antibodies and specialized lymphocytes. In passive, antibodies pass from mother to fetus via placenta or to infant in mother's milk. Artificially acquired active antigens are introduced in vaccines. Body produces antibodies and specialized lymphocytes. and in passive preformed antibodies in immune system in immune serum introduced into body by injection. So now we'll see comparison of active and passive immunity. So active is produced actively by host immune system. So host participation is required in active immunity induced by immunogen or infection. It is durable and effective protection is there, and immunity effective only after a lag period. So some period is required to build up the immunity, that is production of antibodies, so that is called lag period. In passive immunity it is received passively, so host participation is not required. Then it is in ready-made or form it is transferred. It is transient and less effective, and immediate immunity in that lag period is not there because it is a ready-made form. So in active immunity, immunological memory present, booster effect on subsequent dose is present. The negative phase may occur because of the previous antibodies and then not applicable in the immunodeficient persons. In passive immunity, there is no memory, subsequent dose less effective, but no negative phase and applicable in the immunodeficient people. Then mechanism of immunity. So in acquired or adaptive, there is third line of defense. Then we'll see types of acquired immunity. So that we already saw. Acquired immunity is resistance acquired during the lifetime. It is of two types, active, and then active is again of two types, natural and artificial. So example of natural immunity is following natural microbial infection, and artificial is because of the vaccines. And then passive, it is again divided into natural and artificial. So natural example is immunity transferred from mother to fetus, and artificial through the immunoglobulins or ready-made antiserums. Then naturally acquired, it is clinical or subclinical infections. We already saw response to a bacterial or viral infection. Example, chickenpox, smallpox. Artificial acquired active immunity, response to a vaccine of dead or attenuated pathogens. Immunity is provided by the vaccination. Now we'll see few vaccines. So vaccines are preparations of live or killed microorganisms or their products. So there are bacterial or viral vaccines. So and there are different types. So live vaccine, example of bacterial is BCG and viral OPV. Killed vaccine, example in bacterial is cholera, and in viral it is Salk, that is for the polio. Then subunit vaccine, it is typhi VI in bacterial, and viral hepatitis B. Then toxoid, it can be tetanus in bacterial. So we'll see a few differences between live and killed vaccines. So live vaccine advantages: single dose is sufficient, induces local and cell mediated immunity. It is more effective and long lasting, cheaper and used for mass immunization. Advantages of killed vaccine: stable and safe to administer, can be given in combination with polyvalent vaccine, no danger of spread of vaccine oriented infection. Then disadvantages of live vaccine: the reversion of virulence possible, can spread from vaccines to contacts, pre-existing viruses can interfere, cold chain has to be maintained, few cause local and remote complications. Disadvantages of killed vaccine: multiple injections, that is booster dose is required, and local immunity and cell mediated immunity is not induced. Passive immunity. So passive immunity, when ready-made antibodies are transferred to a recipient, the recipient's immune system plays no part. It is called passive. It is only transfer of the antibodies or immunoglobulins. Then it is of two types, natural and artificial. So in naturally acquired from mother to fetus via placenta, or the examples are breast milk, so it contains IgA and monocytes. Colostrum, it contains bifidus factors, antibodies that protect newborn from the gastrointestinal infections. Then IgG, a type of antibody that is transplacental and protects infant up to 3 months. Then artificially acquired from the injection of serum such as gamma globulin. The method of collecting an IgG from an infected immune person and transferring this immunity to an unprotected person, sometimes given to infants who are not producing enough antibodies. Example, ATS and ADS, that is anti-tetanus serum or anti-diphtheric serum. Next type of immunity is adoptive immunity. A special type of immunization is the injection of immunologically competent lymphocytes. This is known as adoptive immunity and does not have general application. Instead of whole lymphocyte and extract of immunologically competent lymphocytes, it is called as transfer factor can be used. This has been attempted in the treatment of certain types of diseases, example lepromatous leprosy.
Hello students, today we will talk about immunoprophylaxis. So prophylaxis is, what is immunoprophylaxis? It is prophylaxis against the microbial pathogens. So it is given in two ways, that is active and passive. So active immunoprophylaxis usually given in form of vaccine. So what is role of vaccine? It stimulates immune system of the body to produce immunity in form of protective antibody by B cells or T cell response. And passive is given by immunoglobulins, which are the ready-made immunoglobulin preparation against pathogenic microorganisms. They act without faster without involvement of host immune system. That is passive. And example is diphtheria antitoxin or tetanus antitoxin. So vaccines are of two types, live and killed. Third subunit recombinant vaccines are also available nowadays. So we'll see difference between live and killed. So live advantages, a single dose is sufficient, which produces local and common, that is immunity, and then it is more effective and long lasting. It is cheaper and usually used for the mass immunization. But disadvantage means virulence may be there because of the live virus is used, and for that cold chain has to be maintained. Killed vaccine, they are stable. Cold chain has no the role in that, and they are safe to administer. No virulence of vaccine virus is there. But disadvantage, you have to give multiple injections or booster doses, and local immunity is not produced. So example of few bacterial vaccines like BCG used for the Mycobacterium tuberculosis, cholera, typhi, tetanus, or viral vaccines like OPV, Salk used for the poliomyelitis. So this is immunization schedule given for the children. So first on the birth, within 1 week of the birth you have to give BCG, then polio, and then 1.5 month, 2.5 month, and 3.5 month you have to give DPT along with polio, hepatitis B, and then after that you have to give booster of the DPT, then DT, TT at the age of 5 years, and then at the age of 9 months you have to give MMR, that is mumps, measles and rubella. You can give vitamin A at the age of 9 months, and then vitamin A booster dose at the age of 16 months, and DPT booster to 5 years, and TT at the age of 10 years. So these are routine vaccination schedule. And hepatitis B you can give at the birth or as early as possible, then after that 1 month, and then 6 months. So 3 doses of hepatitis B, that is 0, 1, 6. So these are common vaccines, and extra vaccines you can use as Japanese encephalitis or Hib vaccine or other vaccines according to the endemic involvement. Thank you.
Hello students, today we will have lecture on antigen. So now we will see definition of antigen. So antigen is defined as any substance that satisfies two immunological properties, that is immunogenicity and antigenicity. So what is immunogenicity? It is ability of antigen to induce immune response in body. And what is antigenicity? It is ability of antigen to combine specifically with antibodies or T cell surface receptors. Now we'll see incomplete antigen, that is hapten. So definition is they are low molecular weight molecules that lack immunogenicity but retain antigenicity. So there are two types again. One is simple hapten and second is complex hapten. So simple hapten is univalent, contain only one epitope, that is antigenic determinant, and complex hapten, it contains two or more epitopes, and haptens can become immunogenic when combined with larger protein molecule called carrier. Means they can produce antibody when they combine with the other protein molecules. Now we'll see antigen host relationship. So it is self or autoantigen, so belong to host itself. So that is that antigen is present inside the host body. The non-self, or it is also called as foreign antigen. That means it is present outside the host body. Then they are again of another different types. So first is alloantigen. So it is species specific antigens are called as alloantigen. This is when the antigens present in a species. Then isoantigen present only in subset of species. Example, blood group antigen, histocompatibility antigen. So they are called as isoantigen. Then heteroantigen. So antigens belong to two different species. Example, heterophile antigen. Now we'll see in detail about heterophile antigen. So what is definition? It is type of heteroantigen that exists in unrelated species, that is different species. Antibody produced against antigen of one species can react with other. So the mechanism is used as a diagnostic application in few tests. So example of that is first is Will-Felix reaction. So it is used for the diagnosis of typhus fever. So in that antibodies against rickettsial antigen are detected by using cross-reacting protease antigens. Then second test is Paul Bunel test. This is used for the diagnosis of infectious mononucleosis. So in these antibodies against Epstein-Barr virus, which is causing infectious mononucleosis disease, so these Epstein-Barr virus antigen are detected by using cross-reacting sheep RBC antigens. So these are two examples of heterophile antigen. Then genetic factors. Then next is the optimal dose of antigen. Then next is the route of administration of antigen. So orally if you give antigen, then there is production of IgA antibody. In inhalation usually there is production of IgE antibody, and parenteral, that is intramuscular or IV, it is production of the IgG antibody. Then site of injection. So hepatitis B injection should be given in deltoid region because gluteal fat is there, and in that absence of APC means antigen processing cells are absent in that. So hepatitis B injection should be given in deltoid region. So site of injection is important factor. Then repeated dose of antigen. So they increase immune response. Then multiple antigens. So immune response is increased. In that adjuvant like action is there. Example of that is DPT vaccination. So in that pertussis act as an adjuvant. Then effect of prior administration of antibodies. So immune response is decreased. So example of that is RH immunization. So in that, if the Rh antibodies, Rh immunoglobulin is given, then Rh antibodies are not produced, and then that is used in the treatment of the or prevention of the hemolytic disease of newborn. Now we'll see biological classes of antigens. So there are two types mainly depending mechanism of inducing antibody formation. So first is T cell dependent antigen. It is also called as TD. An example, all normal antigens are TD or T cell dependent antigens. Then second is T cell independent antigen. So it is also called as TI. So example, bacterial capsule, flagella or LPS, that is lipopolysaccharide, they are T cell independent antigens. And third type is super antigen. Now we'll see superantigen in detail. So definition, they are protein molecules that activate very large number of T cells irrespective of their antigenic specificity, and then they can cause disease. So we'll see examples of the superantigen and disease. So first is Staphylococcus aureus. So it has that enterotoxin which acts as a superantigen, and then it gives rise to disease like food poisoning, toxic shock syndrome. Then second example is group A Streptococcus. In that pyrogenic exotoxin is a superantigen, and then it causes disease like rheumatic heart disease. Then third is Epstein-Barr virus. In that Epstein-Barr virus antigen acts as a superantigen, and then it causes disease like B-cell lymphoma. Now We'll see in short about sequestrated antigen. So what is the definition? So certain self antigens are present in closed system and are not accessible to immune apparatus and are called sequestrated antigens or hidden antigens. So that means they are present in the body but they are in hidden form. So when they get exposed, then they cause reaction and then disease. So they are called as sequestrated antigen. So examples of few sequestrated antigen is first is lens antigen of eye. So it is enclosed in a capsule. So but while doing cataract surgery, if antigen leaks and then it causes immune response and then damage the lens of other eye. Then second is a sperms. So they are in a hidden form. But if mumps infection is there and then in that the leak of the sperms is there, then that causes immune response and then that causes orchitis, that is inflammation of the testes. Then third example is thyroglobulin. So it is present in hidden form, but antibody to thyroglobulin is formed and then that can cause disease like thyrotoxicosis or Graves' disease.
Hello students, let's study antibodies, that is immunoglobulins. What is antibody? Antibody is produced in response to antigens and they react with the antigen. They are protein, also immunoglobulins, part of gamma fraction of serum, found in circulating in blood, plasma, lymph or mucus or fixed to cells or tissues, and it protects against bacteria, exotoxins and viruses. So they are proteins synthesized by host in response to exposure to foreign substances. All antibodies are proteins. Antibodies are gamma globulins or immunoglobulins are produced by B lymphocytes, beta lymphocytes, that is plasma cells, and response to antigens. The structure of antibodies. Antibodies are gamma globulins with molecular weight of 1,50,000. Two pairs of polypeptide chains are there, one pair of heavy chain, one pair of light chain. Two halves are held together by disulfide bonds. The light chain and a part of heavy chain form one arm and remaining part of heavy chain form another arm. The light chain contains kappa, that is corn gold, or lambda lapari. Two regions are there, constant region and variable region. So the variable region end forms the amino terminal, that is FAB, and it is attached with the antigen binding site. The end constant, that is CH, it is carboxy end, it is also called FC. The hinge region is junction between CH1 and CH2 and it is sensitive to enzymatic digestion. Types of antibody is according to H chain and it is designated by Greek letter. So now first is IgG, the H chain is gamma, IgM, the H chain is mu, then IgA, the H chain is alpha, IgD, H chain is delta, IgE, H chain is epsilon. First immunoglobulin is IgG, which constitutes about 70 to 80% of total immunoglobulins of the body. It has maximum daily production and highest serum concentration. The function: IgG can cross placenta, hence provide immunity to fetus and newborn. It is complement fixing, phagocytosis. This IgG plays a major role in neutralization of toxins. It is raised after a long time following infection and represents chronic or past infection. IgA, it is dimeric in nature. It has two monomeric units joined by a J chain. Secretory component. The location of IgA is found in body secretions like milk, saliva, tears, intestinal and respiratory tract mucosal secretions. Function: local or mucosal immunity. It is effective against bacteria like Salmonella, Vibrio, Neisseria and viruses like polio, influenza. Breast milk is rich in secretory IgA and provides good protection to immature infant gut. IgM, the highest molecular weight and pentameric in structure. It present is only in the intravascular compartment and not in body fluids or secretions. Function: it represents acute infection, fetal immunity, protection against intravascular organisms and mediate agglutination.
IgE, it has affinity for the surface of tissue cells, mainly mast cells of the same species. It is extravascular in distribution, mediator of type 1 hypersensitivity. IgE is elevated in helminthic infections. IgD is found in membrane immunoglobulin on the surface of B cells and act as B cell receptor along with IgM. No other function is known for IgD so far. Abnormal immunoglobulins. So Baynes-Jones proteins is one of that. It is found in multiple myeloma. It has many increased light chains of immunoglobulins. The cryoglobinemia, formation of gel or precipitate on cooling the serum, which redissolves on warming. It is seen in myeloma and SLE. Hello students, let's talk about complement. Complement, a group of proteins normally found in serum in inactive form, but when activated they augment the immune responses. Complement components, there are 9 components, C1 to C9. C1 has 3 subunits, C1q, R, S. Properdin system and the regulatory proteins are named by letter symbols, example factor B. Synthesis, liver is the major site of synthesis of complement proteins. Minor sites include blood monocytes, tissue macrophages, epithelial cells of GIT and genitourinary tract. The functions of complement: target cell lysis by MSC, that is membrane. C5a and 5. Hello students, let's study antigen-antibody reaction. Antigen-antibody reactions in vitro are known as serological reactions. They help in diagnosis of infections, epidemiological surveys, identification of infectious and non-infectious antigens. Measurement of antigen and antibody titer or units. So antibody titer of a serum is the reciprocal of the highest dilution of serum, which shows an observable reaction with the antigen in the particular test. The important parameters are sensitivity and specificity. Sensitivity, ability of the test to detect even very minute quantities of antigen or antibody. So false negative results are absent or minimal. Specificity, ability of the test to detect reactions between antigen and its homologous antibody. So false positive reactions are absent or minimal. Murach's or lattice hypothesis. So it is zone phenomenon. Antigen antibody reaction is weak or fail to occur when the number of antigen and antibodies are not proportionate to each other. So first is prozone phenomenon. In the earlier test tubes, antibodies are excess. Hence, antigen antibody reaction does not occur. So it is antibody excess. Post-zone phenomenon in the later test tubes, antigen is excess. Hence, the antigen antibody reaction failed to occur. So post-zone is the antigen excess. So in prozone or post-zone, lattice does not enlarge due to inhibition of lattice formation by excess antibody or antigen respectively, as the valencies of the antibody and antigen respectively are fully satisfied. So in the zone of equivalence, there is the optimal proportion of antigen and antibody. So there is the lattice formation. Types of antigen antibody reactions. So conventional and newer techniques. So in conventional techniques, it is precipitation, agglutination, complement fixation, and neutralization. In newer techniques, it is enzyme-linked immunosorbate assay, that is ELISA, enzyme-linked fluorescent assay, then immunofluorescence assay, radioimmunoassay, chemiluminescence-linked immunoassay, that is CLIA, immunohistochemistry, rapid test, lateral flow, immunochromatographic test, flow through, then Western blot and immunoassays using the electron microscope. Precipitation reaction when a soluble antigen combines with its antibody in the presence of electrolyte sodium chloride at a suitable temperature and pH. The antigen antibody complex forms an insoluble precipitate is called precipitation reaction. So, and then precipitation in liquid medium forms the insoluble floccule is called flocculation. The application of this precipitation reaction, VDRL test for diagnosis of syphilis, RPR test for diagnosis of syphilis, gel precipitation test for diphtheria toxin. Second, agglutination reaction when particulate antigen is mixed with its antibody in presence of electrolytes at a suitable temperature and pH. The particles are clumped. The agglutination is more sensitive than precipitation for detection of antibodies. Mechanism when antibody is added to suspension, it combines with surface antigens and links them together to form clearly visible aggregates. Types direct agglutination, so it is antigen detection, and in that it can be done by slide and tube method. So a slide example Vidal test and tube example Vidal test for determining the titer. Indirect agglutination, detection of antibody, so passive uh, antibody detection, latex agglutination, example ASO, reverse passive antigen detection, latex agglutination method, example RACR. Hemoglobination, so RBC is used as an antigen. Example, pulmonary test for Epstein-Barr virus detection, blood group use test. Third is the complement fixation test, and fourth is a neutralization test. So in that toxin antitoxin neutralization is there. Example is the Nagler reaction used for detection of alpha toxin of the Clostridium perfringens. Precipitation reaction, we already seen the definition. Precipitation in liquid medium, ring test in a narrow tube, example capillary tube, antigen solution is layered over the antiserum. Precipitate ring appears at the junction of two liquids, example streptococcal grouping by Lance field technique. A SCOL is thermoprecipitation test for anthrax. Flocculation test when a drop of antigen is mixed with a drop of patient's serum, floccules appear, example VDRL RPR. Tube flocculation can't test previously used for the syphilis. Precipitation in gel is also called immunodiffusion. Using 1% soft agarose gel for precipitation reaction, many advantages over the liquid medium. Results in formation of clearly visible bands instead of flocules that can be preserved for longer time. Can differentiate individual antigen from a mixture as each antigen forms a separate band. Principle whether only antigen diffuses, single diffusion, or both antigen antibody diffuse, double diffusion. Whether antigen or antibody diffuses in one dimension, that is vertical diffusion, when test is done on tube layer with gel. Two-dimension diffusion in both x and y axis when test is done on slide or petri dish layered with the gel. Types of immunodiffusion in gel. So first is single diffusion in one dimension, Odin procedure. Double diffusion in one dimension or clay fall-through procedure. Single diffusion in two dimension, radial immunodiffusion. Double diffusion in two dimension, Orther-Laning procedure. Example of two this is leachate detecting toxin of Corynebacterium diphtheria. Agglutination reaction when particulate or insoluble antigen is mixed and then it forms the clumps. So in the types, first is direct agglutination. So in this, antigen directly agglutinates with the antibody. Method slide and tube method, and then uses a typhoid fever, Vidal test, acute brucellosis, standard agglutination test, Coombs agglutinin antiglobulin test, heterophile agglutination test. Example, typhus fever, that is Will-Felix reaction, infectious mononucleosis, Paul-Bunel test, mycoplasma pneumonia, gold agglutination test. Indirect or passive agglutination test for antibody detection. Then examples are indirect hemagglutination test, latex agglutination test, and passive agglutination test where RBCs are used as a carrier molecule. Let's study serological tests like RACRP, SO, Vidal, VDRL.
Hello students, today we will see serological test. So first is RA test. So it is rheumatoid arthritis test. So clinical significance is RA test is done to detect presence of rheumatoid factor in patient of rheumatoid arthritis. So rheumatoid arthritis is a disease of the old age patients in that all the joints are major joints are involved. Procedure, in short, you have to take three circles, label it as test, positive control, negative control, add serum to test, then positive control 1 drop to PC and negative control 1 drop to MC, and then add antigen provided in the kit, mix and wait for 2 minutes and then see for the clumps. C-reactive protein CRP, it is also done same way. Take taste, positive control, negative control, and then add serum and then reagent and mix and wait for 2 minutes and see for the clumps. So C-reactive protein significance, it is mainly a inflammatory marker of inflammatory condition of infectious or non-infectious origin. So when the WC count is raised, ESR is raised, CRP is also positive. Antistreptolysin O titer, that is ASO test, it is done for the investigation of rheumatic fever. It is a post streptococcal disease. In that, antistreptolysin O titer is raised and procedure is same as RA and CRP. You do take three circles, test positive control, negative control, add serum, PCNC and add reagent and then mix and wait for 2 minutes and see for clumps. Thank you. Hello students, today we will see serological test, that is Vidal test and VDRL test. So Vidal test is done for diagnosis of the typhoid fever and paratyphoid fever, that is caused by Salmonella typhi and paratyphi A and B. So in that, what is the principle? So in that, four antigens are there: O, H, AH and BH. So O is pink color, sorry, O is blue color and H, AH, BH are pink color reagents. So procedure by slide method, you have to add 1 drop of serum, 1 drop of positive control, 1 drop of negative control, and then you have to add, so the total 4 drops you have to take to add 4 antigens of the serum, and then add 1 drop of OH, AH and BH antigen, mix and then wait for 1 minute and then see for the clumps. So if clumps come within 1 minute, then it is the positive test. So O and H for the typhoid fever, AH for the paratyphoid A fever, and BH If clumps are there, then it is for paratyphoid B fever. Then VDRL test, so it is venereal disease research laboratory test, method by slide method. Again, here you have to take 1 drop of serum, 1 drop of positive control, 1 drop of negative control, then add antigen to each one drop, and then mix and rotate for 8 minutes on the VDRL rotator or by manually, and then see for the clumps. So here you will see floccules. So report can be done if no floccule seen, non-reactive; if weak floccule seen, weakly reactive; if strong floccule seen, it is strongly positive. And then significance, it is done for the diagnosis of the syphilis test, and syphilis is caused by Trypanoma pallidum spirochetes. It is a sexually transmitted disease, and then it should be done usually in pregnancy to rule out congenital syphilis, because in that baby may get stillbirth, IUD, or mental retardation. So that syphilis test is done. Thank you.
Immunodeficiency test, where the RBCs are used as a source of antigen in agglutination test. Then application polymerase test, cold agglutination test, blood group Coombs test for antiglobulin test. Coombs test or antiglobulin test is performed to diagnose Rh incompatibility by detecting Rh antibody from mother and baby serum. So in Rh incompatibility, Rh negative mother with Rh positive baby because of the Rh positive father, and then if the Rh antibodies are incomplete or blocking antibodies. So there are two types, direct and indirect. So in direct antiglobulin test, the Rh antigen is present on the RBCs, and the other RBCs are antibody coated on fetal RBC. So antiglobulin added, that is Coombs reagent, and then Rh antibody coated fetal RBCs get agglutinated. Indirect antiglobulin test, there are free antibodies, Rh antibodies in mother serum, and then reagent RBCs are there. When Coombs reagent added, the Rh antibody coated on reagent RBC gets agglutinated. Complement fixation test. So as the name detects antibodies in patient serum that are capable of fixing with the complements. It was very popular, but now it is obsolete. Application Wassermann test was also widely used for detection of complement fixing antibodies in rickettsia, chlamydia, brucella, mycoplasma infection, and some viral infections such as arbovirus, rabies. Complements are also used for various serological tests other than CFT, like Treponema pallidum immobilization test, Sabin Feldman dye test for toxoplasma, and Vibrio antibody test. Neutralization tests nowadays most not commonly used. Various examples: virus neutralization test, plaque inhibition test, toxin antitoxin neutralization test. Example: shake test, Nagler reaction, ASO test, hemoagglutination inhibition test. Antibodies in patient sera can agglutinate with the hemagglutinin antigens present on surface of some viruses. Was used in past for diagnosis of various viral diseases. Example: influenza. Newer techniques. The first one is the ELISA, enzyme link immunosorbent assay. So principal antigen antibody complex attached with the enzyme plus substrate activates chromosome, and then color change is there, and that is detected by ELISA reader. Enzyme is the peroxidase, immunosorbent is the polystyrene or polyvinyl material, substrate is the hydrogen peroxide. Types of ELISA: direct ELISA to detect antigen, indirect ELISA to detect antibody, sandwich ELISA to detect antigen, competitive ELISA to detect antigen. Application: sensitive test to detect antigen antibody reaction for HIV, hepatitis A antigen, hepatitis B, E antigen, HCV, NS1 dengue antigen, Epstein-Barr virus antigen, HSV toxoplasma. Advantages: test is specific, sensitive, large number of samples tested at one. Mostly used in the blood for the screening of the donors. Disadvantages: costly. Enzyme linked fluorescence assay, modification of ELISA. So it is automated system, and antigen antibody complex is detected by fluorometric system. Application: markers of hepatitis viruses, HIV, antibody to torch, measles, mumps, rotavirus, and H. pylori. Immunofluorescence assay. Fluorescence refers to absorbing high energy short wavelength ultraviolet light rays by the fluorescent compounds and in turn emitting visible light rays with low energy, longer wavelength. Fluorescent dye is used to conjugate the antibody, and such labeled antibody can be used to detect the antigen or antigen antibody complex on the cell surface. Types: direct, indirect flow cytometry. Flow cytometry is laser-based technology that quantitatively analyzes and separates the cells as they pass through the laser beam. Application: detection of autoantibodies, antinuclear antibody in autoimmune diseases, detecting microbial antigen, the example rabies antigen in corneal smear, then detection of viral antigen in cell line inoculated with the specimen. Flow cytometry, CD4 count in the HIV infected patient, detection of leukocyte with specific marker for diagnosis of various lymphomas. Chemiluminescence linked immunoassay, that is clear. Emission of light as a result of chemical reaction. Light is detected by luminometer. The application: detection of antigen, antibodies, hepatitis viruses, HIV, and torture. Immunohistochemistry to detect antigen in cells of tissue section by using labeled antibody. Diagnosis of tumor cells. Western blot detects specific proteins or antibodies in a sample containing mixture of antibodies which targeted against different antigens of same microbe. Procedure: so first SDS page separation of antigen fragments, then nitrocellulose membrane plotting, and third is the enzyme immunoassay. So used as a supplementary test to confirm HIV, Lyme disease, HSV, and toxoplasma. Rapid test: immunochromatography, lateral flow assay, colloidal gold is used for labeling antibody. Application: hepatitis surface antigen, dengue test, rapid malaria antigen test. Flow through assay, protein A is used as labeling antibody. Example: Tridot, HIV, and HCV. Montux test, in vitro detection of sensitization by Mycobacterium tuberculosis. Montux test is performed by intradermally injecting 0.1 ml of tuberculin PPD of tuberculin syringe. For single dose test, 5 TU is used. Uses the diagnosis of suspected infection by Mycobacterium tuberculosis in young children as a post-vaccine check for the efficacy of BCG vaccination. Enzyme link immunosorbent assay. So there are two types, homogeneous and heterogeneous. So in homogeneous, all regions are added at one step and then used for detection of haptens like drugs. And then heterogeneous, so named because of two components, immunosorbent and enzyme. And there is substrate enzyme, the chromogen system added to the final step of ELISA. ELISA principle: antigen antibody complex, enzyme, then substrate is added which activates the chromogen, and there is color change detected by spectrophotometry. And here you can see ELISA reader, ELISA washer, and automated ELISA machine by Biorad. ELISA is performed on microtetraplate containing 96 wells, microELISA, and sometimes in tubes, that is macroELISA. So microtetraplate or tubes are made up of polystyrene or polyvinyl by polycarbonate material. ELISA kits are commercially available, and then procedure involves a series of steps done sequentially, and each step reagent is being added, incubated, and followed by the washing. Types of ELISA: direct, indirect, sandwich, competitive, and ELISpot. Direct ELISA used for detection of antigen in test serum. Primary antibody targeted against serum antigen is labeled with the enzyme. Step 1: well of microtetraplate are empty, not pre-coated with the antigen or antibody. Step 2: test serum containing antigen is added into the wells. Antigen becomes attached to the solid phase by passive adsorption. Step 3: after washing, the enzyme labeled primary antibody raised in rabbits are added. Step 4: after washing, substrate chromogen system is added and the color is measured. Indirect ELISA, antibody detection. So solid phase of wells of the microtetraplates are pre-coated with antigen. Wells are coated with antigen plus primary antibody, that is test serum, plus secondary antibody labeled with enzyme plus substrate chromogen development of color. Indirect ELISA antigen detection wells are empty, not pre-coated. Antigen, that is says serum added, gets adsorbed to well plus primary antibody plus secondary antibody enzyme labeled. Then substrate chromosome development of color. Advantages of ELISA. So it is method of choice for detection of antigen antibody. Sensitive, specific. Disadvantage. It is costly. Application. ELISA used for antigen detection. Hepatitis B surface antigen, pre-core antigen, that is HBe antigen, NS1 antigen for dengue. ELISA can also be used for antibody detection like hepatitis B, hepatitis C, HIV, dengue, EBV, HSV, toxoplasma, leishmania. Enzyme link fluorescence assay. So it is modification of ELISA because it is fully automated system. All steps are performed by instrument. Antigen antibody complex. Antigen antibody enzyme complex is detected by fluorometric method. VIDAS and mini VIDAS are the systems available. Advantage automated system to perform easy, user friendly, less contamination, give quantitative results, more sensitive and specific. Disadvantage expensive. Application infectious diseases, biomarkers like procalcitonin, hormones, tumor markers, cardiac markers, screening of allergy. Immunofluorescence assay, similar to ELISA. The difference is fluorescent dye is used for the labeling of antibody and detects cell surface antigen or antibodies bound to cell surface antigen. Then it is absorbing high energy short wavelength ultraviolet light rays by fluorescent compounds and in turn emitting visible light rays of low energy longer wavelength. And then types are direct, indirect application, detection of autoantibodies, rabies antigen, and viral antigens on cell lines. Flow cytometry, laser-based technology that quantitatively analyzes and separates the cells as they pass through the laser beam. And then application is CD4 T cell count in HIV infected and leukocyte antigen or markers on the lymphoma. Western blot, it is the detects specific proteins in sample containing mixture of antibodies. Southern blot detects DNA fragments. Northern blot detects mRNA. Eastern blot detects carbohydrate epitopes on proteins or lipids. Application supplemental test for the HIV. Rapid test, a point of care test. There are two types: lateral flow, flow through. Immunochromatography, that is lateral flow assay. So the test system consists of nitrocellulose membrane and absorbent pad. Two formats are available: cassette and strip. Application hepatitis B surface antigen. Second method in ICT is the flow through assay. So protein A is used for labeling antibody. In lateral flow, it is gold conjugate. So sample flows vertically through the nitrocellulose membrane, and then example can be antibodies to HIV. This chart is a summary of the newer techniques. So ELISA, in that color change is detected by spectrophotometer, then enzyme link fluorescence assay, fluorometry detection, immunofluorescence assay, emits light and detected by fluorescence microscope, radioimmunoassay, emits beta and gamma radiation and detected by counter, chemiluminescence linked immunoassay, emits light detected by luminometer, immunohistochemistry, color change, naked eye or fluorescence microscope, western blot, color band, immunochromatography, that is from lateral flow and flow through color band measured by naked eye. Hello students, welcome to this session. Let's study structure of immune system and immune response. Immune system cells present in spleen, liver, lymph nodes, thymus, bone marrow and circulate through blood and lymphatic fluid is called as immune system. The lymphatic system it consists of thymus, lymph vessels, lymphatic tissue and lymphocytes. Thymus location, it is bilobed organ present in the root of the neck, above and in front of the heart. Structure, the thymus is enclosed in a capsule and divided internally by cross walls into many lobules, each full of lymphocytes, WBCs, associated with the antibody production. In relation to body size, thymus is largest organ at birth. It doubles in size by puberty, after which it gradually shrinks, its functional tissue being replaced by fatty tissue. Lymphocytes produced in thymus are T lymphocytes. Function: infancy, thymus controls development of lymphoid tissue and immune response to microbes and foreign proteins. In adult, the function is unclear. Phagocytic cells, a cell that able to engulf and digest bacteria, protozoa, cells and cell debris and other small particles is called as phagocytic cell. The types are blood macrophages. They are mononuclear lymphocytes T and B and monocytes polymorphonuclear neutrophil, eosinophil, basophil. Tissue macrophages, histiocytes. So lung alveolar macrophages, liver Kupffer cells. Function of phagocytic cell is phagocytosis. Phagocytosis is the engulfment and digestion of bacteria and other foreign particles by phagocytic cell. Mechanism: the cells move toward the foreign particle. Their abundant cytoplasm produces pseudopodia. Pseudopodia engulf foreign particles. Phagocytosed particle is held inside the vacuole. It's called phagolysosome. It fuses with the lysosome, forming phagolysosome. Lysosomal enzymes digest the particle, the remnants being removed from the cell. Importance: phagocytosis is effective defense against most microorganisms like bacilli of typhoid, tuberculosis, brucellosis. Neutrophils are actively phagocytic and form predominant cell type in acute inflammation. Eosinophilic leukocytes are found in large numbers of allergic inflammation, parasitic infection. Basophils contain basophilic granules, leucine, histamine, serotonin, and other hydrolytic enzymes help in digestion of the foreign particles. Let's study immune response. Immune response, the specific reactivity induced in host by an antigenic stimulus known as immune response. The protection against invading microorganism, reaction against any antigen, consequences beneficial, indifferent, injuries to the host, highly coordinated reaction of the cells of immune system and their products. There are two types: humoral or antibody mediated immune response and cell mediated immune response. Humoral or antibody mediated immune response. So it occurs through 3 6 steps. First, activation of B cells following contact with the microbial antigen. B cells act as APC, antigen processing cells. Proliferation and differentiation of B cells into effector cells and memory cells. Third, effector function, secreted antibodies by plasma cells, which in turn counteract with the microbes in many ways, such as neutralization, opsonization, complement activation, etc. Activation of B cells. Antigens that activate B cells fall into two categories. Most antigens are thymus dependent antigens. They activate B cells indirectly via activation of T cells. The TD antigens are processed by APC, presented to T helper cells, following which the activated T helper cells cytokines produced and that in turn activate B cells. Thymus independent TI antigens, example bacterial capsule, are not processed by APC. They can directly activate B cells without help of T cell induced cytokines. Second, proliferation and differentiation of B cells. The new B cells released from bone marrow go and house in the B cell areas of the peripheral lymph nodes. Example, cortex of the lymph node and marginal zone of spleen. The new B cells are organized to form primary lymphoid follicles. Effector function of AMI: promotes opsonization, transcytosis, mediates mucosal immunity. Transcytosis of IgA to gut lumen provides mucosal immunity by neutralizing the microbes at local mucosal sites. Activates complement mediated inflammation and cytolysis. Promotes ADCC. ADCC is principally cell mediated. Antibodies direct the cells to reach the target cells. ADCC is important to provide immunity against helminths, tumor cells, and virus infected cells, that is NK cells, IgG mediated. Humoral antibody mediated immunity. Primary defense against most extracellular bacterial pathogens, helps in defense against viruses that infect through the respiratory or GI tract, prevents recurrence of virus infection, participate in pathogenesis of immediate hypersensitivity and certain autoimmune diseases. Now, antibody production consists of three steps: efferent leaf, entry of antigen, its distribution and fate in tissue, contact with appropriate immunocompetent cells. Central function: processing of antigen, control of antibody production. Efferent leaf, secretion of antibody, distribution of antibody in tissues and body fluids, manifestation and effects. Cellular or cell-mediated immunity protects against fungi, viruses, and facultative intracellular bacterial pathogens. Participating in rejection, homografts, and graft versus host reaction. Provide immunological surveillance and immunity against cancer. Mediates pathogenesis of delayed hypersensitivity and certain autoimmune diseases. Cells taking part in immune response, antigen presenting cells, B cells, and T cells. Production of antibodies stages: first, antigen capture and processing by APC; second, antigen presentation; third, T helper cell activation; four, B cell stimulation and differentiation; five, antibody production by plasma cells. Factors influencing antibody production: genetic factors, age, nutritional status, route of administration of antigen and site of injection, size and number of doses, multiple antigens, adjuvants, immunosuppressive agents, effect of antibody. Phases of antibody production: lag phase, no antibody is detectable in circulation immediately after antigenic stimulus. Log phase, titer of antibodies rises steadily. Plateau or steady state, equilibrium of antibody synthesis and catabolism. Phase of decline, catabolism exceeds production and titer falls. Primary immune response, the immune response after the first contact with the antigen, usually 4 to 10 days, lag period. Secondary immune response, second contact with the antigen, lag period usually 1 to 3 days. Primary immune response involving B cells, naive B cells. Secondary immune response, memory B cells. Primary peak response time 7 to 10 days, secondary 3 to 5 days. Peak antibody response, primary depends on antigen, secondary 100 to 1000 times more than primary. Isotype generated primary response, in early response IgM predominates, secondary IgG predominates. Antigens thymus dependent and independent, secondary only thymus dependent. Antibody affinity, primary lower, secondary it is higher. Immunization needed, primary comparatively high dose adjuvant there, and secondary adjuvant not required. Primary immune response, initial contact with antigen, slow, sluggish, and short-lived, long lag phase, low titers of antibody, does not persist for long, IgM predominant. Secondary response, response to subsequent exposure to same antigen, prompt, powerful, and prolonged, short and negligible lag phase, very high level of antibody, lasts for long period, and IgG predominant. Here you can see the difference between primary immune response and secondary response. Cell-mediated immune response refers to destruction of cells carrying intracellular microbes and other abnormal cells such as tumor cells by various specific and non-specific cells of immune system, of which the most important is the cytotoxic T cells. Role of CMI: provides immunity against microbes residing in the intracellular environment. For obligate intracellular organisms, CMI remains the only effective immune response. For facultative intracellular organisms, bacteria like Listeria, Salmonella, Yersinia, and fungi such as Histoplasma, Cryptococcus. Immunity against tumor cells and other damaged and altered cells. Mediate delayed hypersensitivity, type 4 hypersensitivity reaction. Plays key role in transplantation immunity and graft versus host reaction. Cytotoxic T lymphocytes, principal effector cells of CMI, involved in destruction of target cells such as virus-infected host cells and tumor cells. Naive T cells, TC cells, that is CTLs precursors, respond to viral or tumor peptide antigens which are processed by target host cells by cytosolic pathway and presented along with MSC class 1 molecules. Activated TC in turn secretes cytotoxic enzymes that lyse the target cells. Function of CTL, target cell lysis. Activated TC cells produce two types of lethal enzymes called porphyrins and granzyme. The porphyrins produce pores in the target cell membrane through which granzymes are released inside. The granzymes are serine proteases. They induce cell death by apoptosis through CAPS pathway. Second, natural killer cells, large granular lymphocytes that constitute 10 to 15% of the peripheral blood lymphocytes. NK cells are cytotoxic but antigen non-specific. Part of innate immunity, act as first line of defense and do not require prior contact with the antigen. Act against virus-infected cells and tumor cells till the T cells are activated and take over the function. Antibody-dependent cell-mediated cytotoxicity. ADCC is exhibited by NK cells secrete porphyrins and granzymes. Macrophages produce lytic enzymes and tumor necrosis factor. Monocytes produce lytic enzymes and TNF. Neutrophils release lytic enzymes. Eosinophils releases lytic enzymes and porphyrins and immunity against ailments. Induction of cell-mediated immunity, infection with intracellular microbial agents, only T cell-dependent antigens elicit CMI. The outcomes of activated T cells. First, helper T cells activate macrophages, enabling them to kill intracellular parasites. Cytotoxic T cells secrete cytokines and destroy target cells. The cytokines, first interleukins, so interleukin 1, 2, 3, 4, 5, 6, 7, 17. And then colony stimulating factors, GM-CSF, G-CSF, M-CSF. Tumor necrosis factors, tumor necrosis factor alpha beta. Interferons alpha beta gamma. Detection of CMI, mixed lymphocyte reaction, in vitro system for assessing T cell proliferation in cell-mediated response. Cell-mediated lymphocytes, lympholysis, in vitro assay for testing cytotoxic function of effector cells of CMI. Graft versus host reaction is in experimental animals, provides in vivo system for studying cell-mediated cytotoxicity. Difference between humoral and cell-mediated immunity. Humoral mediation by antibodies, cell-mediated by cells. Cells involved, humoral B cells along with T helper cells directly bind to soluble antigen. CMI T cells, CD4 Th and CD8 PC cells, T cell-mediated antigens can activate CMI. Mediators, humoral immunoglobulins IgG, M, E, A, and D. Cell-mediated cytokines, lymphokines, monokines, interleukins, and interferons. Role in complement, humoral plays role in, IgG plays role in classical pathway, CMI no role. Hypersensitivity, humoral type 1, 2, 3, CMI type 4. Immunological surveillance, humoral limited role in surveillance and tumor immunity, major role, CMI major role in immunological surveillance and tumor immunity. Transplant rejection, humoral minimal role, cell-mediated major role in homograft rejection and graft versus host reaction. Hello students, welcome to this session on hypersensitivity. Jail and Coons classification. So there are total 4 types. Human immune response in type 1 is humoral, type 2 humoral, type 3 humoral, type 4 cell-mediated. Type 1 immediate, type 2 immediate, type 3 immediate, type 4 delayed. Duration in type 1 is 2 minutes to 30 minutes, type 2 is 5 to 8 hours, type 3 is 2 to 8 hours, type 4 is 24 to 72 hours. Mediator, type 1 IgE, type 2 IgG, type 3 antigen antibody complex, type 4 PDTH cell. Effector mechanism, type 1 mast cell degranulation, type 2 ADCC complement mediated cytolysis, type 3 complement activation inflammatory response, type 4 macrophage activation leads to phagocytosis or cell cytotoxicity. Desensitization to the allergen, type 1 easy but short lasting, type 2 easy but short lasting, type 3 easy but short lasting, type 4 difficult but sustained. Typical manifestations, type 1 anaphylaxis, asthma, atopic dermatitis. Type 2 transfusion reactions, Rh incompatibility, hemolytic anemia. Type 3 Arthur's reaction, serum sickness, glomerulonephritis, rheumatoid arthritis. Type 4 tuberculin test, granuloma formation in tuberculosis, leprosy, contact dermatitis. Type 1 hypersensitivity reaction, production of IgE by sensitized B cells following a contact with an allergen, which in turn induces mast cell degranulation. These changes ultimately lead to localized response called as atopy, systemic response called as anaphylaxis. Experiments to demonstrate type 1 hypersensitivity reaction, PK reaction, Schultz-Dale phenomenon, Antibody-Smith phenomenon. PK reaction. K. Prosnitz and H. Kastner in 1921 injected serum from an allergic person into non-allergic individual intradermally. When the appropriate antigen was injected at the same time, a wheel and flare reaction analogous to hives developed at the site. First, to demonstrate antibodies in the serum are responsible for the allergy and it is transferable from one person to another. Wheel-and-flare response occurs in three stages: appearance of an erythematous area at the site of injury, development of a flare erythema surrounding the site, wheel swelling and congestion forms at the site as fluid leaks under the skin from the surrounding capillaries. Schultz-Dale phenomenon demonstrate anaphylaxis in vitro by exposing isolated tissues such as intestine or muscle segments of sensitized guinea pigs to the allergens. Mechanism of type 1 hypersensitivity. So there are two phases, sensitization phase and effector phase, both occurring with an interval of 2 to 3 weeks. Sensitization phase. Sensitization is most effective. Allergen is introduced parenterally but may occur by any route, including ingestion or inhalation. In susceptible individuals, very minute doses can be sufficient to sensitize the host. Allergen is processed by antigen presenting cells and the antigenic peptides are presented to the CD4 helper T cells. Activated Th cells are differentiated into Th2 cells, which in turn secrete interleukin 4, induces B cells to differentiate into IgE producing plasma cells and memory cells. Secreted IgE migrate to target sites and coat on the surface of mast cells and basophils. Fc region, the CH3 and CH4 domains of IgE binds to high affinity Fc receptors present on mast cell surface. Such sensitized mast cells coated with IgE will be waiting for interaction with the subsequent antigenic challenge. When same allergen is introduced subsequently, shocking dose, it directly encounters with the FAB region of IgE coated on mast cells. IgE cross-linkage initiates degranulation. Allergen bound to IgE triggers the mast cells and basophils activation and degranulation. Granules in turn release a number of pharmacologically active chemical mediators that lead to various manifestations of type 1 reaction. Memory B cells further differentiate into plasma cells that supply IgE. Effector phase, degranulation in two phases. So first, primary mediators, the preformed chemical mediators which are already synthesized by mast cells are immediately released. So examples, histamine, heparin, serotonin. So they increase vascular permeability, increase smooth muscle contraction. Eosinophil chemotaxic factor, eosinophil chemotaxis. Neutrophil chemotaxic factor, neutrophil chemotaxis. Proteases, bronchial mucus secretion, degradation of blood vessel basement membrane. Secondary mediators are those which the mast cells synthesize and release. So the pharmacological actions, chemical mediators increase bronchial and other smooth muscle contraction, increase vascular permeability and vasodilation. And the symptoms are breathlessness, hypertension and shock leading to death at times. So the examples are platelet activating factors, leukotrienes, that is slow reactive substance of anaphylaxis, prostaglandins, bradykinin, cytokines, example interleukin-1, tumor necrosis factor alpha. So they cause systemic anaphylaxis, increase expression of cell adhesion molecules on venular endothelial cells. The mechanism, allergen gets exposed to APC, that is antigen processing cell, then that is CD4 plus T helper cells differentiated into T helper 2 cells, then T helper 2 cells then secretes interleukin 4, then which sensitize B cells, then B cells converted into memory cell and plasma cell. The plasma cell allergen specific IgE allergen. So they get sensitized mast cells, and then re-exposure to allergen, they cause degranulation. So primary and secondary mediators are released, and they cause smooth muscle contraction, blood vessel dilatation, platelet degranulation, then sensory nerve endings, eosinophil secretion. Manifestations of type 1 reaction. So, first, systemic anaphylaxis, acute medical emergency condition characterized by severe dyspnea, hypertension, and vascular collapse leading to death. Occurs within minutes of exposure to allergen and, unless treated promptly, may lead to fatality. Epinephrine, adrenaline is the drug of choice for systemic anaphylactic reactions. Second, localized anaphylaxis, also called atopy. Reaction is limited to specific target tissue or organ, mostly epithelial surfaces at the entry site of allergen, mostly run in families, that is inherited. Examples: allergic rhinitis and asthma. Allergic rhinitis or hay fever, most common atopic disorder, results from exposure to airborne allergens with the conjunctiva and nasal mucosa, leading to appearance of various symptoms such as watery secretion of the conjunctiva, nasal mucosa, and upper respiratory tract, as well as sneezing and coughing. Asthma, second most common atopic manifestation, differs from hay fever in involvement of lower respiratory mucosa, resulting in contraction of the bronchial smooth muscles and airway edema, increased mucus secretion, altogether leading to bronchoconstriction and dyspnea. The stimulus may or may not be the allergen. According to asthma classified, one, allergic asthma induced by airborne or bloodborne allergens such as pollen, dust, fumes, insect products, or viral antigens. Intrinsic asthma, it is independent of allergen stimulation induced by exercise or cold. Food allergy, atopic dermatitis, allergic eczema, drug allergy. Various drugs such as penicillin, sulfonamide may produce type 1 hypersensitivity response, which may be either local or sometimes produce systemic anaphylaxis. Detection of type 1 hypersensitivity. So, skin prick test. So, pricking the skin with required antigen. Advantage: skin test is relatively inexpensive and allows screening of large number of allergens at one time. Disadvantage: it may occasionally sensitize the individual to new allergen, and in some rare cases may induce late phase reaction or even systemic anaphylactic shock. Treatment of type 1 hypersensitivity reaction, avoidance of contact with known allergen, hypersensitization, monoclonal anti-IgG, IgE. So, antihistamines, epinephrine, adrenaline, cortisone, theophylline, chromoline, sodium. So, this blocks calcium influx into mast cells. Type 2 hypersensitivity reaction, host injury is mediated by antibodies IgG or rarely IgM, which interact with various types of antigens such as host cell surface antigens, extracellular matrix antigen, exogenous antigens absorbed on host cells, example drug coating on RBC membrane. Clinical conditions are transfusion reaction, erythroblastosis fetalis, autoimmune hemolytic anemia, agranulocytosis, thrombocytopenia, drug-induced hemolytic anemia, pemphigus vulgaris. Mechanism: antibody Fc activating complement system, antibody Fc interacting with Fc receptors on target cells, autoantibody mediated antibody dependent cellular dysfunction or ADCD. Type 3 hypersensitivity reaction occurs as a result of excess formation of immune complexes, that is antigen antibody complexes, which initiate an inflammatory response through activation of complement system, leading to tissue injury. Antigen involved immune complexes can involve exogenous antigens such as bacteria, viruses, and endogenous antigens such as DNA. Antigen antibody immune complexes stimulate the classical pathway of complement, the products of which mediate the tissue injury in type 3 reaction. Anaphylactoxin chemoattractant. Role of neutrophils. Neutrophil fail to phagocytose large immune complexes. Mechanism of tissue injury. First is the platelet activation. Immune complexes bind to Fc receptor on platelets, leading to their activation. Platelet aggregation leads to microthrombi formation and vasoactive amines released from activated platelets, cause tissue ischemia, leading to further tissue damage. Activation of Hegman factor leads to activation of kinin, which in turn causes vasodilatation and edema. So type 3 hypersensitivity reaction. So first is localized and second generalized. So in localized, it is also called Arthur's reaction. It is defined as localized area of tissue necrosis due to vasculitis resulting from acute immune complex deposition at the site of inoculation of antigen. The reaction is produced experimentally by Arthurs in 1903 by injecting an antigen into the skin of previously immunized animal, that is rabbit. Circulating antibodies bind with the antigen in the dermis and form immune complexes, which leads to fix the complement localized immune complex mediated inflammatory response. That is called Arthur's reaction. So in skin following insect bite or during allergic desensitization treatment wherein repeated injections of the same antigen is given for long periods. In lungs following inhalation of bacteria, fungi, spores or proteins may produce intrapulmonary lesion. Examples include condition causing extrinsic allergic alveolitis such as farmer's lung or bird fancier's disease. Generalized or systemic type 3 reaction. Formation of small size soluble antigen antibody complexes following entry of large dose of antigen in body. Deposition of immune complexes in various tissues, initiating inflammatory reaction in various sites throughout the body, such as blood vessels, causes vasculitis, glomerular basement membrane causes glomerulonephritis, synovial membrane causes arthritis. Diseases associated with generalized type 3 hypersensitivity reactions, connective tissue disorders due to autoantibodies forming immune complexes with self-antigen. Example, SLE, rheumatoid arthritis, antibody against human immunoglobulin, PAN, polyarthritis nodosa. Parasitic diseases resulting from immunocomplex deposition, nephrotic syndrome in Plasmodium malariae, Katayama fever in schistosomiasis, African trypanosomiasis. Bacterial diseases, Streptococcus pyogenes, post-streptococcal glomerulonephritis, Mycobacterial leprae, lepra reaction type 2. Viral diseases, hepatitis B, arthritis, hepatitis C, arthritis, infectious mononucleosis, Epstein-Barr virus, dengue, arthritis. Other hyperacute graft rejection, subacute bacterial endocarditis, serum sickness. Serum sickness seen following serum therapy, that is administration of foreign serum. Example, horse anti-tetanus serum to treat tetanus cases seen in the past. Horse serum proteins being foreign, they induce antibody formation in the host, leading to formation of large number of immune complexes. Typically, after 7 to 8 days, the individuals begin to show various manifestations which are collectively called as serum sickness. Type 4 hypersensitivity reaction differ from other types. It is delayed type, occurs after 48 to 72 hours of the antigen exposure. It is cell mediated. Characteristic cells are TDTH, delayed type of hypersensitivity cells are principal mediators, and tissue injury occurs predominantly due to activated macrophages. Mechanism, there are two phases, sensitization phase and effector phase. So in this diagram, you can see in sensitization phase, there is APC, antigen presenting cells, intracellular bacteria. So there is formation of CD4 plus T helper cells, which leads to activation of the TDTH cells, and they secrete TH1 cells. Then in effector phase, these sensitized TDTH cells, they produce interferon alpha and tumor necrosis factor beta, and then there is resting macrophages which gets activated. So these sensitized PDTH cells secrete cytokines, that is interferon alpha, interleukin 2, TNF beta, then interleukin 3. Then these activated macrophages, they cause activation of class 2 MHC molecules, increase tumor necrosis factors receptors, oxygen radicals, and increase nitric oxide. Type 4HS, the first example is tuberculin test. So tuberculin test is the prototype delayed hypersensitivity in sensitive individuals who possess sensitized DTS cells due to prior contact with M. tuberculosis. When preparation of tuberculin antigen and extract of M. tuberculosis is injected intradermally, there is local reaction development after 40 to 72 hours consisting of induration surrounded by erythema. And the interpretation, when less than 5 millimeter in duration it is negative, more than 5 millimeter it is borderline, but in immunosuppressed persons it is positive. 1 millimeter is positive in IV drug abusers, children under 4 years of old age, and people with high risk area. More than 15 millimeter in duration positive in the healthy person whose immune system is normal. Here you can see how the injection is given intradermally with help of multiple syringe, and then there is edema and induration development after 48 hours of the injection. For hypersensitivity reaction, second example, contact dermatitis. Many antigens such as nickel, poison oak, etc. act by producing DTH response. Most of these substances are haptens. They complex with skin proteins which act as carrier to make the haptens immunogenic. This hapten skin protein complex is internalized by skin APCs, that is Langerhans cells, and then presented to TH cells to induce TDH reaction. Activated macrophages release lytic enzymes which result in skin lesions. Example, redness and pustule seen following contact with the poison oak. Examples of DTH, intracellular and contact antigens inducing DTH. Intracellular bacteria, example M. leprae, M. tuberculosis, Listeria, and Brucella abortus. Intracellular viruses, herpes simplex virus, variola, smallpox, measles virus. Intracellular fungi, Pneumocystis jirovecii, Candida albicans, Histoplasma cryptococcus. Granuloma formation seen in tuberculosis, sarcoidosis, schistosomiosis, and other trematode infection, and lepra reaction type 1. Non-infectious conditions, diabetes mellitus type 1, multiple sclerosis, peripheral neuropathies, Hashimoto's thyroiditis, Crohn's disease, chronic transplant rejection, graft versus host disease. Contact dermatitis following exposure to contact antigens, nickel, poison, IV, poison oak, picryl chloride. Skin test to demonstrate DTH, tuberculin test, that is Montoux test, lepromin test, Montegro test in leishmaniasis, and Fry's test done in LGV. To summarize hypersensitivity reactions, there are mainly two types, immediate and delayed. So immediate are type 1, 2, 3, and delayed is the type 4. And then type 1 is IgE mediated within 2 to 30 minutes, and mediators are IgE and histamine. So examples, this reaction occurs when antigen binds to IgE on surface of mast cells. This produces release of mediators, histamine, serotonin, prostaglandins. Example, drug hypersensitivity, that is penicillin, anaphylaxis, hay fever, asthma, eczema. Type 2 antibody cytotoxic, and then time within 5 to 8 hours, mediators IgG. It occurs when antibody directed at antigens of cell membrane activates complement which damages cell membrane. Example, transfusion reaction, hemolytic disease of newborn, rheumatic fever. Type 3 immune complex mediated, time is 2 to 8 hours, and mediator antigen antibody complex. Mechanism, it occurs when antigen antibody complexes induce inflammatory response in tissues. Example, rheumatoid arthritis, arthros reaction, serum sickness, arthritis, and glomerulonephritis. Type 4 cell mediated, occurs in 24 to 72 hours. Mediators are T cells, lymphokines, and macrophages. It is function of helper, that is CD4 T lymphocytes. Example, tuberculin test. When patient previously exposed to MTB is injected with small amount of tuberculin intradermally, there is little reaction in few hours. Gradual induration and redness develop in 48 to 72 hours. A positive skin test indicates that patient has been infected with agent. Example, contact dermatitis and tuberculosis. Hello students, welcome to this session. Let's study autoimmunity and disorders. Autoimmunity, a condition in which structural or functional damage is produced by the action of first, immunologically competent cells, second, or antibodies against the normal components of the body. So it is protection against self. Injury to self, also called as horror autotoxicosis. Predisposing factors, family history, certain HLA haplotypes, example rheumatoid arthritis, HLA-DR4. Features of autoimmune diseases, elevated immunoglobulins, demonstration of autoantibodies, deposition of immunoglobulins or their derivatives at particular sites like renal glomeruli, accumulation of lymphocytes and plasma cells at the site of lesion, benefit from corticosteroid or other immunosuppressive therapy, genetic predisposition, occurrence of more than one type of autoimmune disorders in an individual, higher incidence among females, usually non-reversible, that is chronic. Pathogenesis, antibodies may cause damage by cytotoxic or cytotoxic type 2 reactions. Example, autoimmune hemolytic anemia, immune complex type 3 reaction. Example, SLE, sensitized T lymphocytes type 4 reaction. Mechanism of autoimmunity. So first is antigenic alteration. Cells or tissues may undergo antigenic alteration as a result of physical, chemical, and biological influences such as altered antigen or new antigens may elicit an immune response. Example, drug-induced anemia, leukopenia, thrombocytopenia. Viral infections such as infectious mononucleosis. Bacterial enzymes such as neuraminidase formed by myxoviruses. Mutation. Second, release of sequestrated antigens. Self-antigens that are present in closed system are not accessible to immune apparatus known as sequestrated antigens. So, immunological tolerance against these antigens is not established in fetal life. Example, Lens protein of eye leaks out due to injury and immune response induced and cause tissue damage. Spermatozoa develop only with puberty. They are not recognized as self and are immunogenic when they enter circulation. Example, in mumps or kites. The virus damages the basement membrane of seminiferous tubules, leading to leakage of sperms and initiation of immune response and subsequently development of orchitis. Cross-reacting foreign antigen. The similarity between some foreign and self-antigen is the basis of cross-reacting antigen theory of autoimmunity. Example, anti-rabies neural vaccine of infected sheep elicit immune response against sheep brain antigen, which may damage individuals' nerve tissue due to cross-reaction between human and sheep brain antigen. Streptococcal M protein and heart muscle share antigenic characteristics. Immune response induced by repeated streptococcal infection and can damage the heart. Nephrogenic strain of streptococci possess antigen found in renal glomeruli. Infection with such strain may lead to glomerulonephritis due to antigenic shedding. Molecular mimicry is due to presence of epitopes with identical peptide sequences in some infecting microorganisms and self-antigen that can initiate immune reactivity leading to autoimmune disease. Example, rheumatic fever, glomerulonephritis. Polyclonal B cell activation. Some stimuli non-specifically turn on multiple B cell clones and multiple non-specific IgM antibodies are formed. Such stimuli include chemicals 2-mercaptoethanol, bacterial products PPD and lipopolysaccharide, enzymes trypsin, antibiotics nystatin, bacterial infection, mycoplasma, viruses, EB virus, parasites, malaria. Forbidden clones, cells against self-antigen destroyed in embryonic life, and persistence of forbidden clones cause autoimmunity. Altered T or B cell function, enhanced helper T cell and decreased suppressor T cells function have been suggested as cause of autoimmunity. Classification of autoimmune diseases, there are total three. First, hemocytolytic, second, localized, that is organ specific, and third system, that is non-organ specific. So here are some examples of organ-specific diseases: brain, multiple sclerosis, thyroid gland, Hashimoto's thyroiditis, thyrotoxicosis, primary myxedema, stomach, pernicious anemia, pancreas, diabetes mellitus, insulin dependent, then adrenal gland, Addison disease, female, premature menopause. Non-organ specific, skin, systemic lupus erythematosus scleroderma, kidney, systemic lupus erythematosus, muscle, dermatomyositis, joints, rheumatoid arthritis, SLE. Hemocytolytic autoimmune diseases. First is autoimmune hemolytic anemia. So RBCs which are coated with antibodies are prematurely destroyed in the spleen and liver. Serologically, two types of anemias with cold and warm antibodies. So first, cold autoantibodies are complete antibodies of IgM class and they agglutinate erythrocytes at 4 degrees Celsius but not at 37 degrees Celsius. Seen in syphilis, primary atypical pneumonia, trypanosomiasis, and black water fever. Warm autoantibodies are incomplete IgG antibodies seen in therapy with sulfonamides, antibiotics, and alpha methyl dopa. Lab diagnosis, Holmes test, the red cells are incubated with anti-human immunoglobulin antiserum. If autoantibodies are present on red cells, cells are agglutinated by the antiserum. Second, autoimmune thrombocytopenia. Autoantibodies directed against platelets occur in idiopathic thrombocytopenic purpura. Syndromid purpura is an instance of immune response against drug-induced neoantigens on platelets. Third, autoimmune leukopenia. Anti-leukocyte antibodies can be demonstrated in serum of patients with SLE and rheumatoid arthritis. Organ-specific localized autoimmune disease. So example, thyroid gland. Graves' disease, the majority of patients with thyrotoxicosis possesses antibodies to thyroglobulin. Symptoms are hyperthyroidism, exophthalmos, tremens. Lab diagnosis, anti-TSH receptor antibody test. Hashimoto's thyroiditis, thyroid proteins and cells autoantibodies targeted against thyroid antigen leads to suppression of thyroid gland. Seen in middle-aged females, hypothyroid state is produced decreased production of thyroid hormones. Myasthenia gravis, characterized by abnormal fatigability of muscles due to malfunction of myonural junctions of striated muscles due to antibodies against its acetylcholine receptors. Thymus shows lymphoid hyperplasia. The lab diagnosis in that anti-acetylcholine antibody detection. Pernicious anemia, two types of autoantibodies are there. So first is directed against parietal cells of gastric mucosa and results in achlorhydria and atrophic gastritis. Second is directed against intrinsic factor and prevents absorption of vitamin B12. So in that, antibody to intrinsic factor is detected. Goodpasture syndrome, autoantibodies bind to basement membrane antigens on kidney glomeruli and alveoli of lungs, followed by complement-mediated injury, leads to progressive kidney damage and pulmonary hemorrhage. So in investigation, biopsies from patients are stained with fluorescent labeled anti-IgG and anti-C3b reveal linear deposits of IgG and C3b along the basement membranes. Then ninth is the autoimmune orchitis can occur as a result of mumps. There is lymphocytic infiltration of testes with circulating antibodies to sperms and germinal cells. Third type is systemic, that is non-organ specific autoimmune disease. So one case study is there. A 27-year-old woman was referred to a rheumatology clinic with history of pain and swelling in the joints of hand and rash on the cheeks. So investigations, immunofluorescent test for anti-nuclear antibodies, that is ANA, showed homogeneous pattern, anti-dsDNA antibody positive. ALE cells were demonstrated on bone marrow biopsy. Diagnosis, systemic lupus erythematosus, SLE, and treatment with low-dose corticosteroid and showed improvement. Systemic lupus erythematosus. So we'll see it in detail. So pathogenesis is a chronic multisystem disease. Autoantibodies are produced against various tissue antigens such as DNA, nuclear protein, RBC, platelet membranes. Immune complexes, self-antigen and autoantibody are formed, which are deposited in various organs. So symptoms are age and sex, women 20 to 40 years of age are commonly affected, and major symptoms are fever, butterfly rash over the cheeks, arthritis, pleurisy, and kidney dysfunction. Lab diagnosis, anti-nuclear antibodies. Anti-nuclear antibody positive in more than 90% of cases used as screening method. Anti-double stranded DNA, dsDNA, highly specific use for confirmation of cases. Anti-SM antibodies, detection of autoantibodies against various nuclear antigens by direct, indirect immunofluorescence assay. Most widely used an ELISA-based technique. ALE cell test no longer used because ALE cells are only found in 50 to 75% of the SLE cases. Rheumatoid arthritis. This is a symmetric polyarthritis with muscle wasting and subcutaneous nodules commonly associated with serositis, myocarditis, vasculitis, commonly seen in women. Major symptoms, age and sex, women 40 to 60 years of age. Main features are arthritis. Chronic inflammation of the joints begins at synovium. Most common joints involved are small joints of the hands, feet, and cervical spine. Other features, hematologic, cardiovascular, and respiratory systems are also frequently affected. Typically, there is a circulating autoantibody called rheumatoid factor RF. A group of autoantibodies against the host IgG antibodies are produced, and they are called RA factor. ACPA, anti-citrullinated peptide antibodies are also produced. Autoantibodies bind to circulating IgG, forming IgM-IgG complexes that are deposited in the joints and can activate the complement cascade. Lab diagnosis, rheumatoid factor. RA factor can be detected by latex examination or ELISA. RA factor is IgM autoantibody directed against the Fc portion of IgG. Anti-CCP, cyclic citrullinated peptide by ELISA. This test detects human autoantibodies IgG against cyclic citrullinated peptide, which can be raised in rheumatoid arthritis. ACP, anti-citrullinated peptide antibodies, is autoantibody to citrulline protein, is highly specific. Rose-Waller test to detect RA factor is of historical importance, no longer used now. Sjogren's syndrome is a triad of conjunctivitis sicca, dryness of mouth with or without salivary gland enlargement, and rheumatoid arthritis. Antinuclear antibodies and RF may be found in sera. Ribonucleoprotein, RNP antigens, SSA, RO, and SSB, LA, present on salivary gland, lacrimal gland, and liver, kidney, thyroid, leads to immune-mediated destruction of lacrimal and salivary glands, resulting in dryness of eyes, keratoconjunctivitis sicca, and dryness of mouth, that is xerostomia. Lab diagnosis, detection of SSA, anti-RO, SSB, anti-LA antibodies by indirect immunofluorescence assay. Hello students, welcome to this session. Let's study immunodeficiency disorders. Immunodeficiency, a condition where the defense mechanisms of the body are impaired, leading to repeated microbial infections of varying severity and sometimes enhanced susceptibility to malignancies. So there are two types, primary and secondary. So primary results from abnormalities in the development of immune system. Secondary, consequences of disease, drugs, nutritional inadequacies, and other processes that interfere with proper functioning of the mature immune system. Primary immunodeficiency. So it is disorder of specific immunity. So it can be humoral immunodeficiency, B cell defects, or cellular immunodeficiency, T cell defects. Disorders of innate or non-specific immunity, combined immunodeficiency, B and T cell defects. Disorders of complement deficiency, disorders of phagocytes deficiency. So clinical suspicion because of recurrent infection, chronic infection, infection with unusual opportunistic infection agents, poor response to antimicrobial agents, chronic diarrhea, failure to thrive, hepatosplenomegaly, autoantibodies, autoimmune diseases. Primary immunodeficiency, in that disorders of specific immunity, so in that we will see humoral immunodeficiencies, that is B cell defects. So the example is Bruton disease. It is X-linked A gamma globulinemia. So failure of pre-B cells to differentiate into immature B cells in the bone marrow. So due to absence of enzyme called Bruton tyrosine kinase, so which causes transformation of pre-B cells into immature B cell. So total absence of B cells and plasma cells in the circulation. Pre-B cells are found in normal numbers in bone marrow, and T cell mediated response are normal. Cytoplasm of pre-B cell may have incomplete immunoglobulin. X-linked primary in males. Sporadic cases may be seen in females. Secondary infections are seen after 6 months. So because of the maternal antibodies are depleted. So recurrent bacterial infection, then viruses that are cleared by neutralizing antibodies, enteroviruses, parasites like Giardia lamblia. Cellular immunodeficiency, T cell defect. Example D. George syndrome, thymic hypoplasia. Results from congenital defect in thymic development leading to defect in T cell maturation. Infants are extremely vulnerable to viral, fungal, intracellular, bacterial, and protozoan infections. Pathogenesis in 90% of cases, there occurs a depletion affecting chromosome 22q11, which leads to developmental malformation affecting the third and fourth pharyngeal pouches in embryonic life. Thymus, parathyroid glands, and portions of face and aortic arch become defective. They may be associated with parathyroid gland hypoplasia, resulting in the neonatal tetany and hypoglycemia, hypocalcemia, abnormalities of heart and great vessels, Fallot's tetralogy, characteristic facial appearance. Treatment thymic transplantation has been found to be successful in restoration of immune function. In others with partial defect, immunity may improve spontaneously with age. Combined immunodeficiency, B and T cell defect. Example, Wiskott-Eldrick syndrome, X-linked recessive disease characterized by immunodeficiency with thrombocytopenia, eczema. Severity increases with the age. First manifests itself by defective responses to bacterial polysaccharide and lower IgM levels, IgG usually normal. Other T and B cell responses are normal initially, but with increase of age, there are recurrent bacterial infection and gradual loss of humoral and cellular response. Prone to develop non-Hodgkin B cell lymphoma, bloody diarrhea due to thrombocytopenia. Pathogenesis genetic defect is due to mutation in gene encoding Wiskott-Eldrick syndrome protein present in precursor lymphoid cells of bone marrow. Cytoskeletal glycoprotein CD43 required for actin polymerization. Nazel-Hoff syndrome, autosomal recessive, cellular immunodeficiency resulting from thymus hypoplasia. In some patients, B cells are normal, wherein other B cell deficiency is secondary to T cell defect. Affected individuals suffer from chronic diarrhea, viral fungal infection, and general failure to thrive. Disorders of phagocytes deficiency, Chediak-Higashi syndrome, leukocyte adhesion deficiency, lazy leukocyte syndrome, Job syndrome, or hyper IgE syndrome. Diagnostic evaluation, lymphocytic function, quantitation of specific cell types using flow cytometry, estimation of T cells by SRBC, T cell Cruzet test, total lymphocyte counts using differential with complete blood cell count, functionality of B and T cells using mitogen assay, functional status of T cells using skin test, serum antibody measurement, bone marrow irradiation. Phagocytic function quantitation studies using differential and absolute white blood cell counts, cell mobility testing using chemotaxis, metabolic function testing using nitrogen blue tetrazolium NBT dye reduction test, killing ability assay using microcytal activity, complement function quantitation of complement proteins using radioimmunodiffusion, functionality of complement using hemolytic assays, various physicochemical methods to detect immune complexes. Secondary immunodeficiency, variety of factors like malnutrition, protein energy malnutrition, anorexia, malignancies like leukemia, Hodgkin lymphoma, drugs like anti-cancer drugs, cytotoxic drugs, immunosuppressants, steroids, infections like AIDS, tuberculosis, chronic diseases like diabetes mellitus, chronic lung disease, others post-splenectomy, protein-losing enteropathy. Diagnosis of secondary immunodeficiency diseases depends on the patient's clinical presentation and diagnostic test available for precipitating illness or condition. Treatment depends on taking care of precipitating illness or condition and immunotherapy. Hello students, welcome to this session. Let's study transplant and cancer immunology. Transplantation, transfer of a graft or transplant, the cells, tissues or organ from one side to another. Individual from whom the transplant is taken is referred as donor and to whom it is transplanted is referred as recipient. Classification of transplants based on organ can be kidney, heart, skin graft. Based on anatomical site of graft, orthotopic graft when tissue or organ grafts are transplanted to their anatomically normal sites in the recipient. Then such are known as orthotopic grafts, example skin grafts. Heterotopic graft are placed in anatomically abnormal sites as when thyroid tissue is transplanted in the subcutaneous pocket. Vital or static transplant, vital grafts, live grafts such as kidney, heart, expected to survive and function physiologically in the recipient. Static grafts, non-living structure like bone, artery, which merely provide a scaffolding on which new tissue is laid by the recipient. Based on genetic relationship between donor and recipient, so the types are autograft, self-tissue transferred from one part of body to site to another in same individual, transferring healthy skin to burnt area in burnt patient, use of healthy blood vessel of same person to replace blocked artery, coronary artery, isograft, syngeneic graft tissue transferred between genetically identical individual monozoic twins. Based on genetic relationship between donor and recipient, the third is the allograft tissue transferred between genetically non-identical member of the same species, kidney or heart transplant. Xenograft tissue transferred between different species, graft of a baboon heart into a man, most commonly used graft in transplant centers. Histocompatibility between graft and recipient decide whether the graft is going to be accepted or rejected. So if they are histocompatible, that means graft is accepted. Example, autograft and isograft. If they are genetically different, antigenically different, then they are rejected. Example, allograft and xenograft. Transplantation antigen, antigens of allografts against which the recipient would mount an immune response. MHC molecules, ABO and Rh blood group system. A minor histocompatibility antigen, peptides derived from normal cellular proteins of donated organ. Immune response against MHA molecules is weaker, hence they pose problems of rejection less frequently than MSC molecules. One exception is when graft is transferred from male donor to female recipient. Types of graft rejection based on time taken for the rejection, types of immune response mounted against the graft and clinical pathogenic features. Three types: hyperacute, chronic, acute and chronic graft rejection. Hyperacute rejection occurs within minutes or hours of the transplantation, characterized by thrombosis of graft vessels and ischemic necrosis of the graft, mediated by circulating antibodies that are specific for antigens of the graft endothelial cells and that are present before transplantation. Exposure to foreign HLA antigens can occur as consequence of the previous blood transfusion, pregnancy, organ transplantation. Develops antibodies against these antigens. If an individual with these pre-existing antibodies to a foreign HLA antigen receives a graft rejected earlier and more vigorously. Not a common problem in clinical transplantation because it can be avoided by matching the donor and recipient. Potential recipients are tested for antibodies against the prospective donor's blood group antigens by cross-matching an HLA antigen by HLA typing. Second is acute graft rejection occurs within days or weeks after the transplantation due to active immune response of the host stimulated by alloantigen in the graft, mediated by T cells, mainly cytotoxic T cells, occasionally T helper, and antibodies specific to alloantigens in the graft. Cytotoxic T cells directly destroy graft cells, or cytokines secreted by T helper cells induce inflammation which destroy the graft. Antibodies contribute especially to the vascular component of the acute rejection. Antibody-mediated injury to graft vessels by complement activation by the classical pathway. Third is the chronic graft rejection, indolent form of graft damage that occurs over months or years, leading to progressive loss of graft function, manifested as fibrosis of the graft and by gradual narrowing of graft blood vessels called graft arteriosclerosis. T cells that react against graft alloantigens secrete cytokines, stimulate proliferation and activation of fibroblast and vascular smooth muscle cells in the graft. Graft rejection. So this is a summary. First is hyperacute. Time taken for rejection minutes to hours. Immune mechanisms involved. Preform antibodies, anti-ABO or anti-HLA. Acute weeks to months. Mechanism cytotoxic T cell mediated. Chronic months to years, chronic delayed type of hypersensitivity mediated, antibody mediated. Autograft acceptance, when say skin graft is transplanted to the same individual at a different site, revascularization takes place by 3 to 7 days, healing within 7 to 10 days, resolution and acceptance of the graft by 12 to 14 days. Graft acceptance and graft rejection. So pathological sequences that take place when skin graft is placed as an autograft to the same donor, allograft to recipient for the first time, and allograft to the same recipient for the second time. So first set rejection is a type of primary rejection when allograft is placed for the first time from donor to the recipient. And second set rejection, if a recipient that has rejected a graft by first set response, another graft from same donor is transplanted, it will be rejected in an accelerated fashion. Mechanism of graft rejection. So graft rejection is caused principally by a T cell mediated immune response to alloantigens expressed on the graft cells, primarily MSC molecules. Peptides present in the group of allogenic class 1 MSC molecules derived from proteins synthesized within the allogenic cell. Class 2 MSC molecules are proteins taken up by and processed by the allogenic APC, antigen presenting cells. The process of graft rejection can be divided into two stages: sensitization phase, which involves alloantigen, mainly graft MSC molecules, presentation to recipient's T cells. Effector stage, which immune destruction of the graft takes place due to activation of recipient's T cells. Sensitization phase, T cells in the recipient may recognize donor alloantigens in the graft in two different ways, depending on what cells in graft are displaying these alloantigens to the recipient T cells. Direct pathway, indirect pathway. Effector phase, delayed type hypersensitivity, activated helper T cells differentiate into TTH cells. Cytokines are secreted, activate macrophages which destroy target graft cells by producing lytic enzymes. Cytotoxic T cells, CD8 plus TC cells kill graft cells by recognizing alloantigens, allogenic MSC class 1 molecules. Antibody mediated mechanism, cytokines produced by T helper cells activate B cells to produce antibodies, mount immune response against graft, mediating hyperacute graft rejection. Acute and chronic rejections minor role. Antibody mediated destruction of graft by complement mediated lysis or ADCC. Laboratory tests to determine histocompatibility. Prior to transplantation, various laboratory tests should be carried out to assess the histocompatibility between donor and recipient. So first ABO blood grouping, RH blood grouping compatibility, blood grouping and cross-matching done, and then HLA typing. So HLA typing, donors antigens expressed on surface of WBCs, leukocytes or their gene to that recipient are matched. HLA compatibility is determined by phenotypic and genotypic methods. So phenotypic method not in use now. Serology, microcytotoxicity, tissue typing, mixed lymphocyte reaction. Genotypic methods widely used: PCR detecting HLA genes, PCR RFLP, restriction fragment length polymorphism, PCR SSOP, that is PPCR, sequence specific oligonucleotide probing. Then PCR SSP, sequence specific primer. PCR DNA sequencing, conformational analysis. Immunosuppressive therapy, hyperacute rejection manifests severely and within minutes, so treatment indicated is immediate removal of the tissue. Chronic rejection generally considered irreversible and poorly available to treatment. Only retransplant generally indicated if feasible, though inhaled cyclosporine is being investigated to delay or prevent chronic rejection of lung transplant. Acute rejection is treated with therapeutic regimens consisting of one or combination of various immunosuppressive therapies. Graft versus host reaction. So graft mounts an immune response against the host, that is recipient, and rejects the host, in contrary to the usual situation of graft rejection in which the recipient mounts an immune response against the graft antigen. So GVH reaction occurs when the following three conditions. So first, graft must contain immunocompetent T cells, that is stem cells or bone marrow or thymus transplant. So recipient should possess Transplantation antigens that are absent in the graft. Recipient may be immunologically suppressed and therefore cannot mount immune response against the graft. Types of graft versus host reaction. Acute or fulminant GVH occurs within 100 days of the post-transplantation. Major challenge in case of bone marrow transplantation. Chronic GVH, less severe form, occurs after 100 days of transplantation. Clinically, acute damage to liver, hepatomegaly, skin rash, mucosa, and intestine diarrhea, mediated grafts immunocompetent T cell. Experimentally, GVH can be produced in mice called run disease. Chronic GVH disease also attacks above organs, but in addition, it causes damage to connective tissue and exocrine glands. Treatment glucose corticoids intravenously. Cancer immunology, tumor antigens of two types, tumor specific transplantation antigen, that is TSTA, and transplantation associated antigen, that is TATA. So tumor-specific transplantation antigens, tumor-specific antigens are present only on tumor cells and absent in normal cells of the body. May result from mutation in tumor cells that generate altered cellular proteins. Cytolic processing of these proteins would give rise to novel peptides that are presented with class 1 MSC molecules, inducing cell-mediated immune response by tumor-specific cytotoxic T lymphocytes. TSTA are induced on tumor cells either by chemical physical carcinogen or also by viral carcinogen. So, tumor-specific methylcholine and ultraviolet light are examples of chemical physical carcinogens extensively studied, and virus-induced are example Epstein-Barr virus that causes nasopharyngeal carcinoma of several types of lymphoma. Transplantation antigens TATA not unique to tumor cells and may also be expressed by normal cells but very low level. Their level gets exponentially high in tumor cells. So there are two types, oncofetal and non-oncofetal. So oncofetal TATA proteins that are expressed on tumor normal cells during fetal life but not expressed in adult normally. Reactivation of embryonic genes that encode these proteins in tumor cells result in their expression on the fully differentiated tumor cells. Example, alpha-fetoprotein embryonic antigen CEA. Non-oncofetal example, carbohydrate antigen CA125, CA199, prostate-specific antigen, and macroglobulin. Tumor markers for diagnosis of cancer. So, oncofetal proteins, alpha-fetoprotein, tumor type is hepatoma, testicular cancer. CEA, carcinoembryonic antigen, gastrointestinal cancer, lung and ovarian cancer. Non-oncofetal secreted tumor antigens, CA125, ovarian cancer, other epithelial cancer, CA199, various carcinoma, prostatic specific antigen, prostate cancer, B2 microglobulin, multiple myeloma, hormones, B subunit of chorionic gonadotropin, highlighted form carcinoma, choriocarcinoma, testicular cancer. Immune response against tumor cells. Both humoral and cell-mediated immune responses are induced by tumor antigens that result in the destruction of the tumor cells. Cell-mediated response appears to play a major role in cytotoxic T cells and NK natural killer cells. Immune evasion by tumor cells. Anti-tumor antibodies produced against tumor antigen may have a role in immune evasion. Blocking factor, anti-tumor antibody may act as a blocking factor. The antibody binds to tumor-specific antigen and masks the antigen from cytotoxic T cells and NK cells. Antigenic modulation. Certain tumor-specific antigens that have observed to disappear from surface of tumor cells in the presence of serum antibodies are then to reappear after disappearance of serum antibody. Masking the immune cells. Circulating tumor antigens may act as a smoke screen, coating the lymphoid cells and preventing them from acting on the tumor cells. Cancer immunotherapy, cytokine therapy involve the removal of immune cells from patient with cancer, either from blood or from tumor. Immune cells specific to tumor will be activated, grown, and returned to the person with cancer, where the immune cells provoke an immune response against the cancer. Cell type that can be used in cancer vaccines include NK cells, cytotoxic T cells, and dendritic cells. Only cell-based therapy currently approved for use in dendritic cells Provenge for the treatment of prostate cancer. Regulate and coordinate the behavior of immune system. Example, interferon alpha is used in treatment of hairy cell leukemia, AIDS-related Kaposi sarcoma, follicular lymphoma, chronic myeloid leukemia, and malignant melanoma. Interleukin-2 is used in the treatment of malignant melanoma, renal cell carcinoma. Cancer vaccine, two types, preventive and therapeutic. Preventive, example, HPV and hepatitis B to prevent emergence of cervical and liver cancer respectively. Therapeutic used to treat existing cancer. Research is going for preparation of such vaccine. Vaccines against some oncogenic viruses have proven extremely effective.
Hope you find this session useful for your understanding and for your exams. Thank you.